I'm Digvir Jayas, Vice President Research and International at the University of Manitoba. These cafes are organized through my office. These were started quite a while ago. And the purpose of the cafes is to bring the researchers from the university in a public setting. And Janine is not here today, but she said the bookstore is probably the most comfortable place. So that's why this location was chosen. And the parking is certainly available. And we typically choose the topics through an internal competition at the university, where researchers would submit a proposal, what would be the topic they want to present, and how they think the topic would be of interest to the public. So the public interest of the topic does play a role in selecting the topic. And today's topic certainly is very exciting and relevant for polypharmacy, which asks the question, are we over-medicating older Canadians? Tonight's experts will be sharing their research knowledge on this topic, and I'm sure you, our audience, will have much to contribute to the discussion tonight. And as the moderator would explain, there's a major role you have to play. You have to participate in the discussion and contribute by asking a lot of tough questions for the panelists. I would like to introduce your moderator for this evening, who will tell you more about the panelists and also will tell you some ground rules that will guide the discussion evening. Dr. Yi-Fan Ko is an assistant professor in the College of Pharmacy in the Rady Faculty of Health Sciences at the University of Manitoba. Prior to joining us, she was a practicing clinical pharmacist and completed her postdoctoral fellowship training at the University of British Columbia before relocating to Manitoba to launch her academic career. Her research program focuses on the evaluation of population health outcomes pertaining to medication use through the lifespan based on real-world evidence, as well as decision-making surrounding drug uses at the patient and administrative level. In particular, she is interested in how drug coverage and reimbursement decisions are made across Canada and subsequent impact on access to the affordable drugs for different demographics. As you can see, she has accomplished a lot in a very short time, so she has a long bio. She has been a Manitoba site liaison for the Canadian Network for Observational Drug Effect Studies, commonly known as CNOTES, and actively engaged with the Association of Faculties of Pharmacy of Canada. Please welcome Dr. Yi-Fan Ko as your moderator this evening, and she will introduce the ground.
Dr. Jayas, and welcome everybody. Thank you so much for being here. So thrilled to see such a crowd. We don't normally get this kind of attention in our own classroom. So this is a treat. I just wanted to make a small correction. I'm most recently as a faculty at the University of Manitoba, but I still have an adjunct appointment status, and it's my privilege to be here and introduce my colleagues. So as Dr. Jaya has mentioned, I'll be a moderator for this evening's discussion, and here's just some overview of how we're going to roll out tonight's panel. So each of our panelists will speak for approximately 5 to 10 minutes on their perspective on tonight's topic, polypharmacy. And after all the panelists have spoken, we'll open the floor up to comments and questions. And I'll be passing around this wireless microphone, so just put up your hand and I'll be around with a mic. And we'll take the last question at around 8:25 p.m. And then wrap things up from there. So this evening's panel presentation are being video recorded and for later uploading onto the Café Scientifique website. And the link to the video will be posted on the umanitoba.ca/Café Scientifique website next week for public viewing. There are refreshments on the site, as you noticed. And also on your chair, you will notice the evaluation forms, which we would greatly appreciate if you can take the time to fill them out at the end of the evening. We would like any feedback that you may have for this event. I would also like to remind everyone before we get started that this is a discussion forum, and we ask that advice on specific treatment or personal problems are not what the presenters are here to provide. So if you may, please restrict your question to being general in nature, so that it can apply to most of us here in the audience. So that brings us to tonight's panel discussion topic, polypharmacy. And I'm going to assume by being here, you all vaguely have some idea of what polypharmacy means, or maybe you have a very deep understanding of what polypharmacy means. And just formally, the World Health Organization defines polypharmacy as the administration of many drugs at the same time, or the administration of an excessive number of drugs. But how many is too many, and how many is considered excessive? So there's no universal consensus or agreement on what that number should be. But we do know that polypharmacy is a common issue that we've observed in the senior population. Which makes sense, because as we get older, we have more chronic health issues for which we will be prescribed medications to treat or manage these health problems. But according to the Canadian Institute of Health Information, in 2016, nearly 2/3 of seniors were on 5 or more drug classes at a time. And nearly 2/3 of seniors, 1/4 were being prescribed 10 or more different drug classes, and almost 10% were prescribed 15 drugs or more. And that's an astounding number, 15 medications. And we're not just talking about taking 15 pills a day. A lot of these medications are taken multiple times a day. So that's a very high pill burden that we're talking about. So why should we be concerned about seniors taking too many medications? Well, we know from studies that polypharmacy is associated with poor outcomes, such as higher mortality rate, higher risk of falls. They also tend to stay in the hospital longer when they're on more medications. And not to mention the unnecessary exposure to side effects from medications. So what does polypharmacy really look like in Canada, and what should we do about it? Does it really matter? Well, that brings us to our panel experts tonight. And they are Dr. Silvia Alessi-Severini, Christine Leon, and Jamie Falk. And they will speak to some of the research that they have done or are currently underway in this area of topic, and some of which would include using administrative databases to look at drug usage patterns in our province, and some clinical scenarios where polypharmacy has become a concern, and also how do we determine the benefit from prescribed medications while trying to minimize the potential harm from using too many medications. So I'm going to introduce our panelists all at the same time, and I'm going to let them speak. So Dr. Silvia Alessi-Severini is an associate professor in the College of Pharmacy at the University of Manitoba, where she teaches at the graduate and undergraduate level in the areas of pharmacoepidemiology and toxicology. She's also an adjunct scientist of the Manitoba Centre for Health Policy and a member of the training team of the Canadian Network of Observational Drug Effect Studies. Her research program focuses on the use and safety of psychotropic medications, and she has been extensively involved with the provincial drug review process in Alberta and in Manitoba, serving on the Manitoba Drug Standards and Therapeutics Committee, the Canadian Drug Expert Committee, and other national committees, including the Association of Faculties of Pharmacy of Canada, the Pharmacy Examining Board of Canada, and the Women's Health Research Foundation of Canada. She also received the Leslie Buggy Professorship in Pharmacy in 2017. Dr. Christine Leon, in the middle there, is an assistant professor at the College of Pharmacy with a cross-appointment to the Department of Psychiatry, Max Rady College of Medicine, Rady Faculty of Health Sciences at the University of Manitoba. She practices as a clinical pharmacist at an interprofessional teaching family medicine clinic. She teaches in the clinical stream at the College of Pharmacy, and her primary area of research is in primary care, pharmacy practice, and education, and psychotropic medication use, using pharmacoepidemiology and qualitative methods. Lastly, Dr. Jamie Falk is an assistant professor at the College of Pharmacy, Rady Faculty of Health Sciences at the University of Manitoba, and practices as a clinical pharmacist with the Department of Family Medicine at the Kildonan Medical Center in Winnipeg. He focuses his clinical research and teaching attention on chronic disease management with the aim of optimizing prescribing practices, minimizing patient burden, and promoting evidence-based knowledge translation to clinicians and the patients they care for. So without further ado, I'm going to pass the mic to Dr. Silvia Alessi-Severini.
Is this working?
Yeah.
Okay. Thank you very much, Ethan, for the introduction, and thank you all for coming. It's really wonderful to see so many people, and like Ethan said, we usually don't get a lot of attention from our students, so it's really wonderful to have you here. What I want to say is that Manitoba is unique for so many things, actually. But one of those things is the availability of a wealth of databases that were initiated and maintained for decades by government departments. And they were started for the use in terms of administrative purposes. But the early work of Leslie and Nora Roos at the University of Manitoba actually made these databases available to researchers to do a variety of studies. These databases were collected in what we call a repository, and which is housed at the Manitoba Center for Health Policy. And so the center has been involved in maintaining and updating these databases, and there is also a source, of course, of a great expertise that can help researchers use these databases. What has set Manitoba apart from other provinces who might have this sort of databases available is the depth and wealth of data that have been collected. As I said, some, for example, hospital data have been collected since the 70s. And there is also a variety of databases that involve the use by the residents of Manitoba in various domains, various services, not only healthcare. So we can get physician's visit, emergency visit, hospital visits, and prescription drugs, but also in services like family services, social services, justice, education, personal care homes. So it's very possible using an identification number to really trace the history and the profile of each resident of Manitoba. But don't be alarmed, the privacy is guaranteed 100%. And that is because that identification number, which is our personal health identification number, is actually scrambled, so it's encrypted, so that the data are actually completely anonymized. So in other words, we can follow an individual through their history, but we don't know who that person is. This is extremely useful, though, to really follow for a long period of time the use of services in the province. Of course, as pharmacists, we are very interested in the healthcare, so we are interested in looking at how the healthcare system is accessed, but mainly on how medications are used in the province. And so we really use what we call the DPIN network, which is a database that is started in 1995, and it captures actually all prescriptions that are dispensed in the province, regardless of insurance coverage. So an individual can have a private insurance or be a client of the government plan or paying out of pocket for their medication, but we still capture everything, which is fairly different from databases that other provinces might have. So our system is really very comprehensive, and the depth and value of the data that we have is really significant. So just to briefly say what I do, my research program is focused mostly on the use of psychotropic medications, so medication that affect our central nervous system, and in particular antipsychotic medications, which were developed over the decades for the treatment of schizophrenia and psychotic disorders. However, there were a new generation that came out toward the end of the 90s that came with the promise of being so much safer than the older generation. So when we talk about older generation, is alloperidol, phenothiazine, and these new drugs were something you probably have heard about, risperidone, quetiapine, olanzapine, aripiprazole more recently. But so they came to the market with a hope that they were so much more safe. And it was true in a sense, but what we look at in Manitoba was that the utilization of these agents actually skyrocketed. But the incidence or the prevalence of schizophrenia or psychotic disorders didn't change. So it was clear that these drugs were used for different purposes. And there was some evidence coming out that it could be used for behavioral disturbances in dementia. And so clearly they were starting being prescribed quite significantly to the elderly population. But at the same time, new adverse events were coming out. And so the question was, are they really much more safer than the others? So what we did, we look at comparing patients treated with the older generation and with the newer generation, and we found that in fact, the risk of myocardial infarction, stroke was not that different. And so the issue is they were treated without having actually the indication for these drugs. And so the harm was more significant than the benefit, probably. In fact, the Health Canada and other health agencies came out with warnings that maybe these drugs should not be used in the elderly population. So another class of drugs that we looked at are the benzodiazepine, and you might, like Valium, this sort of Xanax, these sort of drugs. And again, those drugs have been considered safe. They've been on the market for decades. There's no really evidence of long-term organ damage. However, they've been associated with definitely tolerance, dependence, and even abuse. Furthermore, in the elderly population, they've been associated with a higher risk of falls and motor vehicle accidents. So again, there was this, campaigns actually, and warnings and recommendations and guidelines that would say they shouldn't be really prescribed. So what we looked at is the utilization of these drugs in the elderly population of Manitoba. And there is some good news in the sense that the use had actually decreased in recent years. However, what we noticed is that another drug, which is a zopiclone, is a drug that is mainly prescribed for insomnia. And the utilization of these drugs starting increasing really significantly. And the issue is that it seems it was marketed in a way as a safer drug, but it's different structure, is that right? It's not exactly a benzodiazepine, but in fact, now new evidence is coming out that still it's associated with a higher risk of falls and motor vehicle accidents. So in terms now, we are going to leave it to my colleagues, but we also look, in this kind of studies, if drugs were prescribed concomitantly. And a no-no is to actually prescribe an antipsychotic and benzodiazepine together in the elderly population. Because this, of course, increases the risk, especially because of their effect on, the CNS, their sedating agents, And actually, we did find that they are prescribed together, but again, good news, it's a very small fraction of the population, we are talking about 0.2%. So it's a bit of a good news, but I think it is important that we monitor, how drugs are used, in different populations, and be able to see, the big picture. But so that's what I do. I look at the big picture. I look at what's happening in the population, and then I'm going to leave it to my clinician colleagues who are going to really look at maybe a more specific examples on an individual basis. Because when you decide, in fact, to prescribe a drug, you always have to evaluate the risk and benefit that medications can bring to the patient.
Good evening. Like Dr. Alessi-Severini, I've also done research using the databases at MCHP, looking at pattern of medication use in the Manitoba population. So specific medications that I've looked at include benzodiazepines as well, antidepressants, antipsychotics, and also prescription cannabinoids. But I'm going to talk a little bit more about my clinical practice. So I'm a pharmacist at a family medicine clinic. And at this clinic, I do carry out some medication reviews or medication assessments with patients. Patients that I typically see, these patients are usually on 6 or more medications, or they've recently been discharged from the hospital and have just had all their medications changed. So just to provide a couple of examples, just last week I saw 2 patients. One was a 92-year-old male who had 0 medications prior to being hospitalized for a stroke, and then was discharged on 8 medications. And then there's another patient I saw, a 63-year-old male who was already on 9 medications to start with and was hospitalized for chest pains that required stents to be put into place, and was discharged on a total of 15 different medications. And so these are just some examples, and polypharmacy is not necessarily a bad thing if the medications are actually meeting the health needs of the patient. Some of the medications that are added after a heart attack or stroke can be life-saving, but it just becomes a problem when the benefits no longer outweighs the risks. And so by benefit, we would ask things like, is there actually evidence where there were studies that were done on patients of the same age group as you, as the same gender, ethnicity? There are some groups that are often underrepresented in clinical trials, and certainly older adults, particularly over 80 or over 85, are often underrepresented. So is there evidence to say that this drug is actually effective in people that are similar to you? And is there evidence for continuing a medication for years and years after a drug is being initiated for a symptom that was meant to be treated for? So an example is proton pump inhibitors like omeprazole. That's probably one of the #1 drugs that I see during these medication assessments, where someone had started on these medications 20 years ago to treat heartburn, and their heartburn symptoms are no longer there, but they still kept taking the medication, but perhaps there's no benefit with continuing on this medication, and there might be some rationale to maybe come off this medication. So that's what we think about in terms of benefits, and then the risks. We think about what are the known side effects of this medication, what are the potential risks for adverse effects, and also are there any potential age-related changes that can affect how we respond to the medication or how our body actually handles the medication. There are many changes that our body undergoes as we age, and that can affect the way medications work. So just as an example, the way we break down medications in our system or metabolize the drug to help eliminate the medication from our body can slow down as we age. The amount of acid that's in our stomach, for example, the production of acid can slow down as well. And also medications, or our kidney function can also slow down, which some medications are primarily eliminated through the kidneys. So also other things that we think about are other medical conditions and drugs that can potentially interact with the current medications that you are on. Just a number of factors that we think about that may require an alteration to the current medication that you are on over time. And certainly these things is what we think about because it can contribute to your risk of having an adverse drug reaction. Just a bit of data, we have, there are up to 25% of adults over 65 taking 5 or more medications that have been reported to experience an adverse drug reaction, and up to 20% recently discharged from hospital can experience an adverse drug reaction as well. So when I do medication assessments, I basically look to see if the patient is receiving more medications than actually is needed or is safe. And I do this by considering quality of life issues with the patient that I see in front of me. So I look at physical functioning. Are you mobile? Are you able to get around? Are you able to do activities of daily living like go grocery shopping or doing other things that are important to you? Mental functioning, is there depression? Are you alert? There are some medications that can affect that, like benzodiazepines. We also look at social functioning and overall health as well. And then I probably want to mention at the top 3 types of polypharmacy issues that I've seen during these medication assessments. One is when the requirement of the drug is no longer needed, just over time. So this can include blood pressure medication. I saw a 92-year-old with a blood pressure of 110/60, for example, and was on 4 different antihypertensive medications. You could probably go down on some of those medications. Another example is prescribing cascades, and so this is where one medication is started to treat a symptom, but then that medication has side effects, and so another drug is added to treat the side effects of that medication. So an example of that is Tylenol PM. So Tylenol PM contains Tylenol, or acetaminophen, and an antihistamine, a first-generation antihistamine, which can cause, it's like Benadryl or diphenhydramine. It can cause sedation, and it can cause constipation. And I often see patients started on that, and then they develop constipation, and then they start on Docusade or Senna. So that's just an example of a prescribing cascade that I've seen. Other examples include when there's just no evidence for benefit. So one example is Docusade for constipation, or really high doses of vitamin C for immunity boosting. Our body can only absorb so much vitamin C, and then you kind of pee out the rest. And then other examples include duplication of therapy and also drugs that kind of oppose each other as well. So what we can do, we can consider de-prescribing some of these medications, which is what we've done at the clinic, oftentimes with regular follow-up. So this involves going down on the dose or stopping the medication. And there are quite a few tools out there that patients can access, and clinicians as well. One is deprescribing.org, has a lot of patient tools that are specific to medication classes like benzodiazepines, proton pump inhibitors, some diabetic medications as well. And I have some example resources if afterwards you want to see. There's another tool that some clinicians use called medstopper.com as well. And so all these tools really just can help identify some of the drugs that may require additional monitoring or some intervention, but not necessarily the final word, because the decision about medication use really needs to be individualized. But those are just some of the examples that I can kind of talk about about clinical practice, and if there are any other questions, I'd be happy to address them.
So I'm going to guess that a number of you have probably heard of Atul Gawande. He wrote the book Being Immortal. If you haven't read it, please. Are there birds in this tree? Gawande is Gawande. You can probably find him on these wonderful shelves here. So he wrote a book called Being Immortal. He's written a number of other books. He's a physician, he's an author. In 2015, he wrote an article in the New Yorker, and he entitled it, "An Avalanche of Unnecessary Care is Harming Patients Physically and Financially." And he was speaking from an American context, which is where he's from, but if any of you were at the Choosing Wisely session last month here, you will have heard that we struggle with this in Canada as well, and obviously on a smaller scale, but probably proportionally pretty similar, that we struggle with unnecessary care. And when we think about the contributors to unnecessary care, as a pharmacist and researcher, my mind goes to what are the contributors to overtreatment? And I think the obvious one is when we have overdiagnosis, and this is a fairly new term, at least probably within the last 5 years. The Chief Medical Officer in Australia just a couple of weeks ago was cited in the Sydney Herald as saying overdiagnosis is exposing healthy people to tests and treatment that are probably no better than useless. And so this is an international thing, certainly within advanced health systems where we deal with overdiagnosis. And in overdiagnosis, we're not talking about expanding the boundaries of disease to those more severe. Those people will always be covered in the definition. We're talking about expanding it to people that were once considered healthy. Now they have a disease because that definition has been expanded by a society. And we get concerned with that because what that can mean is that if you are making healthy people sick, those sick people then, do they need treatment? And that's where we get into overtreatment. Where my mind often goes is there are obviously a lot of scenarios where we have very appropriate diagnoses being made, and those appropriate diagnoses lead to appropriate treatments. But the first point on that is does treatment need to be a drug? And so we have many examples where a change in diet, or an increase in exercise, or physiotherapy, or behavioral therapy, or counseling, all of these things may be the first line as a treatment. When drugs are the default treatment, overtreatment comes fairly quickly after that. The other thing that I probably spend most of my time thinking about in my clinical practice and in my teaching is when we've got a scenario where a medication was a very appropriate starting point for a patient with a confirmed diagnosis, and that net benefit was found to be there through an informed decision-making process with that patient, looking at, for you particularly, do the benefits outweigh the harms of this therapy? The question that we have to ask, and Christine alluded to this already, is as we go down through the years, does that net benefit still exist for that person? And we have to ask that question for that particular person, not for a general population with that disease, but for that particular individual, is net benefit still there? And so that leads us to have to ask the question, how do we define benefit and how do we define harm? We need both of those to understand what a net benefit is. And so when we think about benefit, Christine alluded to that, well, we need evidence. We need evidence that for this person, there is some type of benefit that exists. Where the patient comes in is, do they care about the outcome that's been shown to be positive? I have a classic example that I share with my students all the time of an 84-year-old gentleman that I was called in to see to talk about going on a drug called a statin to reduce cardiovascular risk. And I had looked through his chart and I saw that he was 84, and I got into the room and I started talking to him about translating some of the numbers that we have, and we have some pretty good tools to be able to translate this. And before I was done, he got to where I was hoping he was going to go. He said, "Do you know how old I am?" And I said, 84. And he said, besides that number, I've lived a great life. I don't care if I die of a heart attack tomorrow, so why would I take a drug to prevent something I don't care about? And that is so important for us to understand and gain an understanding of with our patients, that our values and our goals of treatment aren't the same as theirs. And so I think that's the thing that, first of all, we have to understand when we think about benefit. It's not only does benefit exist for a population, but does the patient value that as one of their goals of care? The second part is harms. And so we often think of safety, we think of day-to-day annoying side effects, we think of long-term side effects that we haven't encountered but are a potential for this drug. But there's also burden. So taking a medication every day, maybe taking an insulin injection 4 times a day. What is the cost of that medication? What are the tests and treatments that now we have to do because we started you on that treatment to show that it's either effective or not causing negative aspects that we didn't want? So there's a lot to both of those questions that need to be engaged with the person in front of us. There's no equation for that, unfortunately, but there's a great endocrinologist and researcher at the Mayo Clinic in Rochester named Victor Montori, and his research group is looking at how do we create effective healthcare systems that respect the capacity of patients where they are right now, not only in the complexity of their disease, but the complexity of their life. How do we create a matrix to figure out how we fit all of those things together? And that's what their research group is doing. They're calling it minimally disruptive medicine. It's not minimizing care, it's not minimizing medicine. What it's doing is trying to provide care that fits that patient. And I think that's where we need to go. In the US, there have been a lot of studies over the last decade looking specifically at diabetes in older populations. And they define older as 65, sometimes 70, so I apologize. That's not how I think of it, but that's how they define older populations. They've used, you can imagine with Medicaid, Medicare, Veterans Affairs, they have massive numbers of people that they can follow using similar databases like that we have in Manitoba. They've asked the question, are we too intensely dropping blood glucose in people that are of older age? And diabetes, I think, is a great example of this research question, why we should ask it. So we know that dropping blood sugar makes a difference in preventing complications. The problem is that it usually takes up to a decade or more to see a difference in those complications by lowering blood sugars intensely compared to taking a little more relaxed approach with it. The differences are also quite small. When you compare that with the potential harms, those are going to be immediate. You can imagine if you drop blood glucose too aggressively, the harms are immediate, but we have to wait decades to see the benefits. The harms are going to be more pronounced as we get older, and so that's why these US groups have started looking at this question. So one of my master's students, Sai, is going to look at this for his master's thesis, and we've just gotten access to the data now, and we're going to look at it from a broad Canadian context in primary care, and then we're going to link that to the Manitoba Centre for Health Policy databases that have already been talked about to see locally in Manitoba, looking at the diabetes population 65 and older, how intensely are we treating? So we're looking at overtreatment in that population. And we're also going to look at how many comorbidities or other coexisting conditions exist. How many medications are they on in total? What are the costs of those medications? How frequently are we testing people to see if these medications are working? So we're looking at burden. We're looking at burden of care, and our hope is that we're doing much better than the US. So what I haven't told you is the US, very consistently, all of these studies line up to show that elderly populations are being intensely treated. Those that are most vulnerable and at high risk, they're not pulling back on therapies. And this is something we've consistently done poorly, is that we put medications on and we don't take them away when they're no longer needed. My last example is a study we did in COPD. So we looked at the population of Manitoba, and we looked at chronic obstructive pulmonary disease, or emphysema, or chronic bronchitis. And our average age in this population was somewhere between 65 and 70. And we wanted to look at prescribing patterns. Our concern was that maybe patients were being added more and more and more therapies on top of one another. The problem with that approach in COPD medicine is that what we've found is that we know that stopping smoking is by far the best thing a person can do to help that condition. Next in line comes inhalers. A lot of patients don't find massive improvements with inhalers. Clinical trials have always been able to see improvements by using inhalers, but they've had to use statistics to see those differences because they're so small. The story gets worse as you add another inhaler on, and then you add another one after that, because the benefit gets smaller and smaller and smaller and smaller, but the burden gets greater. We have more inhalers, we have definitely more cost and sometimes more harm. So what we found, unfortunately, was that 1 in every 8 patients who had a new diagnosis, had never been on a COPD medication, was started on 3 medications. 1 out of 4 was started on 2 medications. And we know the combination that was most prominently used of those 2 has been shown in clinical trials to likely cause more harm than good. The other finding we found was from the late 90s to 2013, which was our study period. What we found was that inhaler costs per person tripled despite almost no improvement or advancement in care. So this is really concerning. We're not doing a great job of this. Again, taking those away is the difficult thing. It should be easy to do, but we've made it really difficult to do. So I think what can we do? Number one, we need to make changes in academia in how we teach students about sharing decisions, looking at the person in front of us, not at broad populations that have a disease. The other thing, as we get better in doing that, the responsibility falls on the population to take the responsibility of being empowered to ask the right questions, I think. And Choosing Wisely has some really nice guidelines on that, of the questions to ask. Do I really need to be on this medication? We need to empower people to feel comfortable asking that question. Are there any downsides to this therapy that is being proposed? If I don't do anything, what will happen? Last question, I think, would be, is there something simpler? Is there something safer that I could be on? So I think I'll just end it there, and I guess we can open it up.
Thank you so much, panelists. Interesting work that you guys have worked on. Lots of good perspectives that's going to make us think for a long time to come. So I'm going to open up the floor for questions at this point. I'll be your roaming holder of the mic. So just put up your hand if you'd like to make a comment or questions. And in the meantime, please feel free to go ahead and use some refreshments on the side table as well. So who's going to be the lucky person to pose that first question?
Thank you very much. It was a great pleasure to listen to you all talk. I have a question about the use of atypical antipsychotics in the elderly. I understand, and I think it was from CAI, there was data that looked at the decreased use of atypical antipsychotic use in nursing homes, predominantly, to the use of antidepressants, which carry similar harms and less benefits for people. Are you tracking that information? And in your database, do you know whether or not people who are on antipsychotic use, the atypicals, whether they died as a result of the negative side effects, like with the neuroleptic malignant syndromes?
Thank you very much. This is a very good question. So in our study, we did look at individuals who were in the community, so they were filling prescriptions at their community pharmacy, and those who were in the personal care homes. And the difference in prescribing is dramatic. In the personal care homes, it was, I think it went up to 40%. Where individuals were treated with antipsychotics. There was some evidence brought up, a few years ago that actually brought indication for risperidone in treating behavioral disturbances, in the elderly. And so it is true that after the warnings, because yes, the difference, if you compare to the older generation, where it was known that, they have significant side effects, especially movement disorders. that can be permanent. They don't improve if they quit the medication. So they were better in that sense, but the effect on cardiovascular and cerebrovascular, actually there was not much difference. In our data, we found that actually a slight difference in mortality. It seems that those who were on the first generation antipsychotic, phenothiazine, haloperidol, they had higher risk of mortality. But in our studies, unfortunately, there is always a possibility of bias. We certainly make adjustment to make sure that we take into consideration the different comorbidity, the individuals, and adjust for that. So there might be still a little bit of confounding there, but that was a positive thing. I don't know if you had another part of the question that I might have missed.
The other part was the collection of data secondary to the use of antipsychotics, specifically like the neuroleptic movement syndrome.
Okay. The neuroleptic malignancy syndrome is very rare event. And so I'm quite sure I haven't actually looked at that specifically, but I'm quite sure that the database could pick up that for sure. However, yeah, we need to be, there are some limitations in when the number of events is very small. We cannot really have the statistical power to do any, statistics and some comparison. So, but definitely something that we can look at. And so I have students who are continuing working on the use of antipsychotics. And the interesting part, if I can say, because I always like to put some good news, in the sense that it is true they have been used, what we say off-label, is that right? It's not for the schizophrenia, it's not for the psychotic disorders, but for individuals who have a diagnosis, and there are still elderly who have the diagnosis of schizophrenia and these disorders. The only option is really medications, and so they have really brought benefit, to those individuals that can live a normal life, if they're quite effective. In terms, you also had asked about antidepressant, and I think there have been a switch to try and replace, the antipsychotic with antidepressant. However, they're not without adverse events as well. Cardiovascular side effects has been reported also for antidepressant, and we always come to the consideration of the risk benefit really for the individuals. I don't know if I have answered your question.
I think I'll just add to that picture. So I think what comes up from that question is, as Silvia, as you were alluding to before, as benzodiazepines came down, zopiclone came up, and it's kind of this unintended consequence of kind of trying to get certain drugs out of the way, other ones rise up, and I think the problem there is that we think, well, what could replace that? Well, it's another drug, but does it have to be, right? And antidepressants, although they maybe don't have the mortality harms that we've seen with antipsychotics in dementia, we certainly know that they increase fall risk. They have a laundry list of side effects, especially as we get older. And so I think what comes to mind is there was a systematic review. So systematic review is bringing a whole bunch of clinical trials together to try to find if there's an answer that maybe individual trials couldn't have found by themselves. And a group called the Cochrane Collaboration, which is one of the biggest systematic review groups in the world, looked at music therapy in dementia. And they found that music therapy reduced some of the behavioral symptoms. It improved mood. There were a list of things. I think there was only one out of maybe the 4 outcomes that were not positive. And this gets to the kind of idea of not reaching for another medication to solve our problem because we had to let the other one go. It's engaging that patient and that patient's family to say, what would mom or dad like? What do you think would make them happy? And now we have some evidence that things like music, simple music sessions, can actually elevate a person's mood.
And I think another good example is when you guys mentioned antidepressants. We know cognitive behavioral therapy is probably just as effective as drugs, but our current health system is not necessarily set up for everyone to have CBT. So, you know, food for thoughts. Yeah.
My question won't be as sophisticated as this person's. Pharmacological interactions. Have you considered those with alcohol, caffeine, and now marijuana? I mean, we often hear about not taking alcohol with X, Y, and Z pharmacological interventions. But caffeine comes to mind, of course marijuana comes to mind, and maybe other things that I hadn't thought about. So those combinations, I guess we're just beginning the marijuana thing.
Why don't you go ahead?
Yeah, we certainly think about those things too, and before legalization of cannabis, we've always asked about other medication use that's not prescription drugs as well, because I think they certainly can contribute. I think cannabis is similar to alcohol in that they can contribute to sedating effects, compounded when you're already on medications that can cause sedating effects. So certainly, we definitely keep those in mind. Yeah, and caffeine, when we think about that, to me becomes more of an issue for in patients who may have had insomnia and they started a medication to help with insomnia. We often think about caffeine in terms of drinking caffeine close to bedtime. Perhaps you should limit it to early afternoon because that can certainly keep some people awake. So yeah, I think we certainly think about all those things as well.
Yeah, no, I don't have. Unfortunately, I can talk about the limitation of using the databases. We cannot capture what are the lifestyle of individuals, so it's not reported. Even though now there is actually hope that this network of databases will improve with the with electronic medical records, so that physician can actually ask this kind of questions. Also the alcohol consumption, it's not usually reported. So unless it's a problem, unless it's substance abuse, So hopefully with the new electronic medical records, we'll be able to capture also the lifestyle of the patients and therefore account for that in our assessment.
Yeah, that's a good point. So CIPSIN, which is what we're using for our diabetes project, is an EMR, electronic medical record. So a primary care or family physician office will have an electronic record, and you can pull from that. Right now, the lifestyle part of it isn't all that robust, and that's probably because we're not asking the questions often enough. But the hope is that that will be a key difference with that type of database that we can pull from to look at lifestyle factors. And cannabis would come into that as well.
It seems to me that when I listen to you talk about polypharmacy and comorbidity and that kind of thing, and then when you're doing med reviews with individual people and developing healthcare systems to serve individuals, that you're kind of lifting up a whole paradigm or optic that we're not living out of right now. Like right now, you go to see your individual doctor, that doctor writes a prescription, you go to the pharmacist and you get this prescription, you go home. But you don't really have this, what you're talking about is kind of a team approach, even for the average individual. There's a team approach right now if a person is a patient in either a hospital or a PCH, but you don't really have a team approach for the average person who's in their own home. Perhaps in a clinical situation you might. So, but I'm hearing that you're going into, or you're going to into conversation with people and actually doing a med review with people and looking at their lifestyle with people. And I'm wondering about the conversation with medicine, with the doctors. Like, where are they in this? Because they are the ones who actually prescribe. Yeah? So where's medicine in this, and where's a team approach?
Yeah, well, I can speak to my clinic that it is an interprofessional multi-professional team. So I do work in close relationship with the physicians, and we're all on the same page when it comes to polypharmacy and doing a yearly medication review for these patients. I think the culture is shifting slightly, and I think there certainly could be some improvements, as Jamie had mentioned before, just integrating it early in the medical system, education system, and also pharmacy as well, and other healthcare professions. But certainly, I think the culture is shifting, and there's more tools that are out there now, more data that we're collecting in terms of what the risks and benefits of polypharmacy is, and the risks and benefits of deprescribing some of the medications as well. So, yeah.
Yeah, I think if you think of the roles that Christine and I have, there's probably a dozen of us in the province that work within a family medicine, primary care type center. I don't know if you've heard of my health teams. So that's a new concept that has started within the last number of years, where practices will I don't want to use the term virtual team, but there's a number of individuals that are devoted to a number of clinics, and they will see patients within those clinics. So I think that there is a shift that's happening under the current political system. There's some, I think, resistance to that, but I think with time and good example of what can be done, my hope is that it will continue to shift in that direction.
If I can say this, it was back in 2005, I guess, that there was the Romanov report where they were actually anticipating and recommending that pharmacists would take a bigger role into, teams. And so it's happening. It's never too late, I guess, but yeah, my colleagues are doing that. So, and we have been educating our students to actually go out and really participate in this multidisciplinary and multi-professional teams. So it's coming.
And just to add that too, in other provinces outside Manitoba, pharmacists in drugstores do have the directives at times to do these comprehensive medication reviews as well. Especially when they are taking multiple medications. We don't see that yet here in our province. There are reasons for that, which I'm going to, but it is an issue that's recognized nationally, and we're trying to make amendments to that. So.
I guess I have a question, and all that we've heard is, I've heard pieces of it, and I'm in this system in a clinic, and I have two issues that are sort of being looked at. But I guess I also have to ask the question, when you're my age, what do you do about ageism? What do you do when a doctor says, well, haven't you had a good life? Yeah, I have a great life still. And I think I should be able to question, what can't I do? What will I do that will harm? So it's not all pharmacy. It's all, because you're bombarded with how much exercise, how to eat, how much sleep. I mean, you can spend all day reading about what's good for you. But then you keep getting patted on the head and said, well, you've had a good life, So how do we deal with the ageism factor? Because that is how all of us believe what is old age, and how do we live it best?
Well, what I can say is that I really resent, we say, in our studies, we talk about we try not to use elderly anymore, we use older adults, which is over 65. So since I'm approaching that age, I really resent also the term older adults. I think that it's a matter of health, is that right? So you can have individuals who can be in their 80s and be much healthier than younger people. So I don't have the answer, you know, it's just, I think it goes back to, you know, the individual, when you make your decision based on your treatment, on your lifestyle, on your, with the physician and with the, you know, healthcare professionals that can advise you, you know, what is best for you, having, you know, the information that we can provide as much as possible.
And I think that's a very good point that you brought up too, because when I do meet with patients and we talk about what are their individual goals, I certainly don't want to make any assumptions for that patient, and I'd like to hear from the patient about what's important to them. So as I mentioned, quality of life, there's different aspects to what quality of life means to every individual, and it's very unique. And so certainly when we think about polypharmacy and whether it's appropriate to start de-prescribing or to cutting back on some of these medications, we do look at it from an individual by individual basis. And in partnership with that patient, they have to have a say in what's important to them.
Yeah, I think when I, using the example of the 84-year-old that I talked about, I think the important, there's a few important points that come from that. One is that it's just a number. And what I was excited to hear from him is his perspective on what that number meant to him. And again, it wasn't the number that meant it to him, it was the life that he had lived in those years, whatever those years were in number. And that at that point, he was good. He was good with that. But the engagement needs to come to kind of ask questions of our patients of, so what are your goals? And I think you can put the whole age number aside when you ask that question, just say, what are your goals of care? And that's one of those open-ended questions that I think you can gain a lot from, but you have to listen to the answer, I think is one of the important parts of that. So I think it's a really good question that I think we continue to struggle with.
A friend of mine who recently moved to BC told me, and I hope I've got her correct here, but she said that she can have access to her healthcare record, everything, all tests, everything that she's on, so that you know, obviously she can be more involved in managing her care, and she's a former nurse, so that's very helpful to her. Are we anywhere near that in Manitoba? Is that on the horizon anyway?
Well, what I can say is that in your pharmacy, you can request the list of your history in terms of prescription that you have received. Because even if you fill your prescription in different pharmacies, because of this DP network, every pharmacist can actually access your record. So at least from the pharmacy perspective, if you don't remember, you know, because you might want to say, okay, what did I take, you know, 10 years ago, you know, the record should be there. But in terms of other tests, I think you have to, I mean, you are entitled to know, but you have to ask your doctor, I guess. It's not sent to you directly.
Yeah, at my clinic they talked about this specifically, actually, and right now they're discussing about how to do it at our specific clinic in terms of having a login access, and then you can access information related to your health. But I think we're far behind where UBC or British Columbia is at. So.
Right. Yeah. I think, like you said, you can ask for anything that you want, but we haven't provided the slick avenue of you having access to it without asking anyone. And I think sometimes the provincial privacy issues come into that, and how do we work around that? And I wonder if that's probably one of the barriers, but there's probably a number of them.
Just to add to the question, when I was at the Canadian Medical Association Health Summit this year, they were talking about, because they want it to be electronic, digitally recorded, patients having access to their record. So that is the Canadian Medical Association's plan, is for you to have access to your record and be part of the ongoing care that you receive. So I know that it was something that they were going to be doing.
I just would like to mention, since we're talking about polypharmacy, excuse me, I think it should be mentioned about all the over-the-counter non-prescription drugs people take, and they don't tell their doctor they're on it. And so many of these medications are not scientifically proven, and they have very bad adverse effects, especially with cardiology medication. So you might want to say something about that.
Oh yeah, that's a good comment to bring up. I certainly always ask about over-the-counter medications and natural health products and other vitamins and supplements that people are on. And yeah, I could talk for a long time about certain medications that may not have that much benefit. But yeah, I think it's good.
Yeah, I think, I don't know, 75% of the products in the OTC aisle could be taken away, and no one would be worse. We'd probably be better off, to be honest with you, maybe 90%. So I think they're most, I mean, we think of things that are over the counter as being safe, and that's how they got there, but that's just because Health Canada decreed them to be safer than prescription options, which I think in a lot of cases, and you bring up Tylenol PM or anything that helps you sleep, is not safe for a lot of people. And so, yeah, I think it's something that I ask about as well, but even right now in our electronic health record, it's kind of the miscellaneous column is where we list that. It needs to take a more front and center approach, I think.
You know, the internet has and then the paper, some cracks.
You know, on the internet and then in the papers, some doctors that aren't really credible are advertising stuff like CoQ10 or whatever it is, shark's tooth. I know people that take this and they're just wasting their money, and yet it's all up here. They think they've read something not scientifically proven, and there could be some harmful effects. Or they think because something's natural, it's safe. It doesn't mean that at all.
You know, strychnine is a natural product.
I watch a fair amount of TV, and an awful lot of many ads are about takes, such and such a prescription drug for, eczema, bipolar, psoriasis, whatever it is. I wonder what the effect of that is on doctors prescribing those medications, because people must go in and say, I saw, maybe I should be on that.
And it's true, in Canada, actually, the direct-to-consumer advertising is not allowed, but of course, with cable TV, we can see all the American channels, and it's true. And so the pressure that the physicians have sometimes from the patient is to prescribe, the latest, the most, because there is always this idea that the newest product is the best. And it's not true, because, even though they've been tested, we assume that they're on the market, they're considered safe and effective. But as what we see when we look at the population, when, these medications start being prescribed to a larger number of individuals, who are not selected like in the clinical trial, so they might have comorbidities, they can be, older, and we can start seeing adverse events that are quite significant and more dangerous, maybe of the old drug that have been on the market for decades, and some people don't want it anymore because it's not the new one.
The solution is using a PVR.
I think if I could just comment, one of the other problems is that, again, what ads do is they sell sickness, right? The Loan Institute in the US, which is a really good organization, just put out a series of ads that they came out for Halloween because they said these are terrifying people. And they were ads about if you haven't had your first heart attack, you should be worried that you will. It is really, right? And this is not what we should be doing. That's one part of the problem. There were some studies in the early 2000s that looked at US drug company marketing and found that 35% of their budget went towards physicians. When they looked at Canadians, now this is kind of, I think it was around 2008, every Canadian doctor on average, that doesn't mean they all took money, but on average, each physician was devoted basically $15,000 of a budget for a drug representative. Those are startling numbers, but we know that money in anyone's pocket changes one's decision-making capacity, no matter who you are. And so I think that's concerning as well.
I'm very curious, what should we believe about aspirin?
We could be here the whole night.
We've always known that it's highly effective in reducing your chance of having a second bad event. So if you've had a stroke, if you've had a heart attack, it reduces your chance of having another one and your chance of dying. So we don't have much better drugs than that in preventative care. But when we talk about aspirin, and I'm assuming you're talking about once a day, daily aspirin, we've known for quite a number of years that the benefit and the risk probably come out right in the middle, meaning you can prevent long-term events, but you got to treat many people if they've never had an event before by giving them aspirin. But you probably cause as many people, or close to as many, to have a gut bleed of some kind. Just this last year, we had over 50,000 patients studied in four randomized trials that spanned anywhere from 5 to 7.5 years. We'll never get a better answer than this, that ASA, for people that haven't had an event, is not worth it.
Any other comments or questions from the floor?
Maybe I can say about the aspirin again. It's I don't know. She's one of my ex-students. I used to do a survey with my students and say the 10 best drugs of all times. And the one that was voted the most was aspirin. It was number one, you know. Because if you think about it, it was used for centuries.
Right. I spoke at a conference last weekend, and one of my slides was, can we please stop studying aspirin and vitamin D? And the reason for that was because of these big ASA aspirin trials that came out, and that we've just had, in the last year and a half, we've had 2 massive, again, systematic reviews on the vitamin D question. When we look at conditions outside of bone health, we either don't have enough data to answer the question of whether vitamin D is helpful, or we have enough data to say it's not. Now that's for people that aren't deficient. When we look at bone health and osteoporosis and prevention of fractures, we've got now a big lump of studies that encompasses about 50,000 patients that says for community-dwelling people, vitamin D does not prevent fractures. My slide said, should we be throwing out motherhood and apple pie? Because that's what we've been saying for years, is anyone over 50 or 60 should go on vitamin D. We have 2 big systematic reviews now, the last one just coming out within the last month or so, saying that in community-dwelling people, at least those of kind of general risk of developing a fracture, vitamin D is not helpful. But again, we're talking about people that have never had a fracture. Those that have, that's a different scenario. But when we're talking about kind of the broad population, probably the answer is we don't need to be on vitamin D. everyone asks the question, what about Manitoba though? Because we stay inside, huddled beside the fire in winter, and we don't get, the sunshine that we need. This systematic review did look at whether you had low levels of vitamin D or high levels, and it didn't appear to make a difference. But they are kind of pulling little subgroups out, and we have to be careful when we start making that population much smaller, which is what they had to do to find those with low levels versus high levels. But in that population, they couldn't find a difference of whether your levels were low, which is, again, where you get sunshine from, or whether it was high. They couldn't see a difference in fracture risk.
Well, what about all the other benefits of vitamin D?
Yeah, because but I kind of leave vitamin D alone if the patient is on it, in my opinion. But that's because I came from, when I was a student, I worked at a multiple sclerosis clinic, and everyone was on vitamin D, especially in Manitoba. Like Jamie said, that potentially we're not getting enough with sunlight, and it's not often harmful as well. There's a lot of side effects up to 1,000 units a day. In the MS clinic, they were taking about 2,000 units a day. Some parts of the world, they're getting so much more with just exposure to sunlight. So I kind of leave it alone. But I mean, I do agree with Jamie in terms of the evidence. Maybe it's just not there. But
Yeah, I think we've got a lot of unknowns, and I think if people say, but I've heard that there's a benefit for this, my usual answer is there might be. We're not sure yet, and because there's a pretty good safety margin on it, meaning you can take probably 2,000 units or more and be safe with the many thousands we've studied. I do kind of leave it alone if people want to take it as well, but my stance is I don't promote the use of vitamin D.
My wife says I should take vitamin D, and I do what I'm told.
That's very good.
Just listening to you, you brought up a number of things. Like, we had my parents that we moved here from another province in around 1990, and fairly soon after, because my mother was taking this, that, other which for pills, and we were at the doctor, and my wife said I wanted her to go to a heart specialist and find out. So we did that. The heart specialist said she should be taking none of these pills whatsoever, and one of them was the number of pills she was taking for her heart. He says there's nothing whatsoever wrong with her heart. So I don't know about the doctor she was going to, but I don't want to mention names. No, I'm not mentioning names. And then there was another thing about having something to drink when you're in a nursing home or towards the end. And we had, my mother was prescribed 1 ounce of sherry a day. And we were told that they doubted that she really knew what it was, but she smiled every time she did. And just to say, my mother lasted until she was 99. My father 96, so I got a long time.
The last session that we had here, 3 people sitting up there all said take
I think the moderator at the last session was an orthopedic surgeon who sees people with fractures. So again, that's a different scenario.
But I think I would like a glass of sherry towards the end of my life.
Sounds good.
Maybe tonight.
Sounds good.
Now I'm really confused about the vitamin D thing. I was at the doctor on that one.
The mic closer.
Vitamin D deficient. I'm vitamin D deficient, that's what the diagnosis was. So,
Put the microphone next to your mouth.
are deficient.
So I think that, just to repeat the question, I think you were at the doctor, and the doctor said you were vitamin D deficient. So what do we say to that?
I mean, if you've had a vitamin D level and it's been shown to be deficient, then yes, you would, just like if we had an iron deficiency. we would treat that with iron. So whenever we're talking about whether you would supplement with a vitamin, we're assuming that we're talking about someone who hasn't had a test to say, because we don't do vitamin D tests in the vast majority of people for good reason, and they would have probably brought that up at the Choosing Wisely session last month, that we don't have the capacity or the reason to do it. But if it has been done because there are certain people that will need that done, that would be certainly appropriate.
Well, I mean, the one example is just the risk. They've found with observational studies, those that live in parts of the world where they don't get enough sunlight, vitamin deficiencies seem to be associated with multiple sclerosis, as an example.
Would one of the panelists like to speak about how a lot of these claims were based on observational studies, and thus adding to the confusion of why we keep hearing mixed messages about a vitamin D or another thing being helpful, and then at times it's not helpful anymore?
So just in one of our classes today, we had a discussion about how do you address fake news and spin, and we didn't discuss fake news because fake news are just lies, and those are either true or they're lies, and I think the spin is the thing that we see in the media all the time. The news items that come out, we trust, I think for good reason, that journalists and news organizations will pick up a story that is based on some finding that actually exists, but it's the spin on that finding and what the implications are for society that just cause a lot of problems. There was a recent study just a couple of weeks ago in JAMA Internal Medicine that showed that if you eat organic food, you reduce your risk of cancer by 25%. And that's how it was reported in the Times of London. That's how it was reported by CNN. We reduce our risk of cancer if we eat organic. But none of those news stories had anything about all of the confounding factors that could play a part in there. So who are these people? What does eating organic mean? How wealthy were people that eat organic because they can afford it? Does that mean their life is different, their cancer risk is lower? There was a long list of this may apply, but not to these people, these people, these people, these people, and these people. So anytime we have an observational study like this where we look back over time, there are always going to be massive questions, and probably the most we should do with that is use it as a hypothesis to say, now we need to actually study this.
I think there was a question here.
Where does one go to avoid the fake news or to get the true facts on either a medication or a vitamin of some sort? Like, I'm sitting here listening to all this and I thought, okay, I can go and ask Google whatever I ask Google, but Google's going to give me some more fake stuff. So there has to be a place where we can go find.
Yes. Well, you know, the government agencies like Health Canada, the website is providing also information for the public, and that's a good place to go. Other, agency like the FDA in the US. In Canada, we have also CADAT, which is the Canadian Agency for Drug and Health Technology, and Technology in Health, so it's CADAT. They have a lot of good information about medication, especially the newest medication. They do reviews of the evidence. So yeah, definitely do not Google. Do not Google. Because the first thing that comes out is not right, as a rule.
What was that last website?
It's a CADAT. It's a CADTH, and it's the Canadian Agency for Drug and Technology in Health. Yes, that's a good one. Yeah,
Yeah, so the Mayo,
maybe you have other suggestions.
the Mayo Clinic has, so Victor Montori that I was talking about, the endocrinologist, their group, it's CUR, I forget what that stands for, but they have a group of decision tools that are designed for clinicians and patients to use together. So things like making a change in a diabetes medication, depression medications, osteoporosis medications, cardiovascular medications, a bunch of tools that clinicians and patients can use together. So patients can go onto that site and look at them on their own, but they're designed for a conversation to be had. So there's certainly some good stuff in the Mayo Clinic that you can look at. If you're looking at preventative health, the Canadian Task Force has some very good pictures, graphics, infographics to help us understand what screening is appropriate for me, if that's kind of the angle that you're looking at. So I think generally when patients ask that question of me, I say, well, what do you want to know? What are kind of the general avenues that you want to go down? And then I have kind of a list of things.
And from a deep prescribing perspective, I mentioned medstopper.com is something that we've used in clinic, and it's kind of neat because you can put in all your medications and it'll give you like a smiley face or a sad face depending on whether or not it's worth being on that medication or not. And then deprescribing.org also has a lot of pamphlets that deprescribing.org. Deprescribing.
So it's
DE.
Yeah.
Right. Sorry. Yeah.
Yeah. It's a Canadian group that got a fairly nice grant for a really good reason. What they wanted to do is develop guidelines to help clinicians help patients take medications away that weren't needed, and how do you prioritize that? And so they developed tools for clinicians, and now they're also developing some of those tools for patients as well.
So I think we have time for one very quick question. I saw one hand up there.
Just on the opposite side, the concern that I have, I worked in the Inflammatory Bowel Disease Clinical Research Center. A lot of our patients, some were older, some were younger, but they couldn't afford their medication. So there's the other side of that, whether DPN is actually monitoring all those people who don't fill their prescriptions and the cost to healthcare of underutilizing the prescribed meds.
Yeah, unfortunately, the DPN captures the prescription that are dispensed. We don't know who has been prescribed but never make it to the pharmacy. But that's a major issue, and you know, we say that in Manitoba everybody is covered, is that right? Because there is, it's based on, the pharmacare is based on income, you have deductible, but theoretically everybody is covered. But you know, it depends on how much your income is that right? And what is your disposable income? And you shouldn't spend your disposable income on medication. So then it becomes a bit political. But yes, it's out from the databases. We don't know. Unfortunately, it's dispensing, so we don't know if it's prescribed. And but we certainly can monitor cost. We can monitor how much the province, for example, for the antipsychotics, we noticed that in fact the majority of the medication were actually covered by the drug program, but other classes of medications may not, especially those that newer ones that are becoming so expensive, so it is an issue.
I know there's like the database that Jamie is working with that uses the electronic medical records. There were talks about looking at, and that's called primary adherence, where they get a prescription and then they don't fill it at the pharmacy. And I think they were thinking about linking it with DPN to see what exactly is the percentage that don't actually fill that first prescription they get from the doctors.
Yeah, so we're actually doing that with our diabetes study. We're going to link the primary care database with the center's database to see of those that are getting something prescribed in primary care, how many of them are actually filling it, and does that change with socioeconomic status? Does it change as we age? Does it change as we have more and more coexisting conditions because we just can't keep up, right? So we're hoping to find at least a beginning of some of that, but we're exploring that avenue as we make this linkage between these databases.
All right, well, I think that's a wrap for tonight. Thank you everybody for coming out. supposed to do a little bit promo here for our next event, which is going to take place on November 27th in this very same space, beginning at 7 p.m. And the topic is titled, "Is Canada a Safe Haven? Experiences in Resettling Refugees in Canada." So please do join us for that discussion, and that will focus on current debates, issues, research on that topic. The panelists will discuss several aspects, including our duty to protect others, the true economic costs of resettlement, and misconceptions that shape false attitudes and beliefs, while providing insight from professional fields to improve public knowledge. The discussion will be moderated by Winnipeg Free Press reporter Carol Sanders. Just a reminder, please do fill out the evaluation form if you can. We really do appreciate feedback. And there's still some refreshments. And we may stick around, so if you have any additional questions, just feel free to stick around.